name's Clare Ridell and I work at Pressure Point. I'm based in Arnold near Nottingham. I'm a sports massage therapist and lecturer. So today we're going to be having a look at foot and ankle anatomy. We're going to be looking on a live model. I'm going to be looking on different anatomical structures. So just to introduce the foot, we've got 28 bones that make up the foot, which include the shin here, the tibia and the fibula. We've got 33 joints in total, 112 ligaments, 12 extrinsic muscles and 21 intrinsic muscles. So you'll probably be glad to hear that we're not going to be looking at all those today, but I'm going to point out the major ones and how to palpate them on a client, which will make your treatments better. So whether you're a reflexologist, sports massage therapist, having knowledge of where the tendons are, where the ligaments are, is really useful. I'm going to be having a look at foot arches. So just as a quick one before we look on our live model, it's divided into three different parts. We've got the rear foot, which is the calcaneus and the talus bone. We've got the midfoot, which are the three cuneiforms, the navicular and the cuboid. And then we've got the forefoot, which is the metatarsals and the phalanges. So as the foot stands, there'll be contact with the calcaneus around the fifth metatarsal to the heads. So we're going to have a look on our model here and have a look at his natural foot arch. So there's not a lot of gap here between the arch and the floor, but this is the medial arch. So the foot has three arches. There's a medial longitudinal arch, which is this one. There's a lateral longitudinal arch, which is under the fifth metatarsal, and then a transverse arch, which goes across underneath, across the foot. And we can see here on Mark that he does look fairly flat. Now we've got a test that we can use to see if this is structural or functional, and it's called Jack's test. So what I'm going to do is I'm going to dorsiflex the big toe or the hallux. So as I lift that up, you can see the foot arch forming, and relax. Okay, just do that again and relax. So when you dorsiflex the hallux and you see the foot arch forming, that shows it's a functional flat foot rather than a structural flat foot. If there was no movement at all when I bring the big toe up, no change in foot arch, that would show it was more structural. Another thing we can have a feel of here is just inside on the talus bone. So at the moment where I'm palpating, I can feel the talus bone here protruding a lot farther than this side. Okay, and if I get my client to try and even up their foot slightly, so bring that foot in, just roll over. No, not that, that's it, good. Okay, so now I've got fairly equal palpation in the talus, and we've got a foot arch, and if client relaxes, and you can see that foot arch flattening, and now I can feel the talus head. So it's another way to identify whether there is any flat feet, which is pes planus. A pes cavus, come right up onto that, give yourself a nice big foot arch. That's it. Pes cavus position would look more like that, and just relax. We're going to be looking at bones of the lower leg and the foot now. So we're going to start off at the top here. So we're on the tibia. There's a knobbly bit here called the tibial tuberosity, and that's the attachment for all four quadricep muscles, which extend up into the thigh. It's quite easy to palpate, especially if the client, just bend your leg slightly, there we go, and you can hook your fingers around the corner here. So that's the anterior medial shaft of the tibia. You can feel it run all the way down to the bottom and straighten your leg. And then we get down to the bottom here, and this is the end of the tibia. So we know this as the medial malleolus. Most people would call that the inside ankle bone. Okay, so we know it's part of the tibia, but the medial malleolus is the technical name for it. If we drop down about 2.5 centimetres from the medial malleolus, there's a little ridge of bone in here called the sustentaculum tali. Now that's part of the calcaneus, which is the heel bone, and it means it's a plank-like structure which supports the talus on top of it. It's also an attachment for one of the ligaments, the deltoid ligaments crossing over. So in terms of our bony landmarks, I'm just going to draw a few of these on. So we've got the bottom of the tibia, so that's the medial malleolus. We've dropped down and we felt that little ridge of bone. That's the sustentaculum tali, and that's part of the calcaneus. Calcaneus is going to extend down here, so that's the main heel bone. Just above the calcaneus is another bone called the talus, so that sits above it. And then we get to this bone here, so it's quite easy to palpate, and this one is the navicular. So the navicular is one of the 7 tarsal bones, and then the next bone on from that is the medial cuneiform. So there are 3 cuneiform bones in total. There's a medial, there's an intermediate, and then there's a lateral in that order. And then we have the metatarsal. So this is the first metatarsal. The first metatarsal goes down to the big toe. And we know the toe bones are the phalanx bones or the phalangeal bones. Now in the toe, the big toe, we only have 2. All other toes of the foot have 3. So here we have a proximal phalanx and a distal phalanx. So the big toe's missing a middle phalanx. All the other toes have them. So in total, in one foot, we have 14 phalangeal bones. And moving to the lateral aspect of the lower leg, I'm going to feel where the fibula is. Now, we know the fibula is on the outside. I always find it from kind of mid-calf upwards, and it's the first bony landmark you get to, which is here, so it's pretty prominent. If you try and find the head of fibula from the knee area, there's another bony landmark that's actually really close to it. So these 2 structures. So this is the head of the fibula, and this is the lateral tibial epicondyle, okay, which is why I always find the fibula from here upwards. I'm just going to draw that in. So the fibula bone is a lot smaller. The tibia is a nice big chunky bone, and it's the weight-bearing bone of the body. The fibula is more for muscle attachments. So you can actually break this bone and still be able to walk around, whereas if you broke your tibia, you'd be struggling for that one. So it disappears underneath this muscle group. The fibula is going to head down this way, and the other end of the fibula you can feel is down here at the ankle. So opposite to the medial malleolus now, we have the lateral malleolus, the outside ankle bone, lateral malleolus. Okay, and the rest of the fibula is underneath this set of muscles. From this structure, we can locate another bony landmark. So dropping down around 2.5 centimetres or an inch, there's this little ridge of bone here called the peroneal tubercle. And the peroneal tubercle is a bony landmark, so the peroneal muscles come down here and they hook around that tubercle, and we'll talk about those 2 in a bit. So we've got the peroneus longus and brevis. From here, if we go forward, we can feel this bone. This bone is the cuboid. Okay, and it is fairly cuboid shape. And then down from the little toe, there's a really big bony landmark here, and that's the end of the 5th metatarsal. Very common footballing injury is to have a break or fracture of the 5th metatarsal. So that's that one. And then, as I mentioned, with the big toe only has 2 phalangeal bones. The little toe, even though it is pretty small, has 3 sections. So just draw those 3 on. So we have a proximal phalanx, a middle phalanx, and a distal phalanx. From the head of the fibula, which we've drawn on here, we've got 4 main attachments to that bone. So we've got a ligament that goes up this way, the LCL, the lateral collateral ligament. We've got the bicep femoris. So the bicep femoris is part of the hamstring group, and you can see that thick tendon here coming down from the hamstrings, has an attachment on the head of the fibula. Also from this view, we've got the soleus. So the soleus is a deep calf muscle which has an attachment on the head of fib and around to the tibia. And then the 4th attachment on there would be the peroneus longus, which is going to come around to the bottom of the foot. So they're the 4 attachments off the head of the fibula. If we come down to the ankle joint line here, where's my black pen? Thank you. We've got the main ankle joint. So we did say there were 33 joints. We're only looking at 1 today. Fibula, tibia, and then in between the 2 in this area here. It's called the talar dome. So I'm just going to draw the bottom of the tibia in there. And then underneath there, you've got the talus. And the talus sits underneath it like a wedge. And this is an example of a modified hinge joint. So this is the talocrural joint between the talus and crural, Latin for the leg, talocrural joint. Again, from the head of the fibula, we've got a nerve. It's part of the sciatic nerve that comes down and branches, and this one around the head of the fibula wraps around. It's called the common peroneal nerve. Now, if you have any impact, contact, any trauma on the outside of your leg, it can aggravate that nerve and send pain signals down the leg, on the lateral leg, and also into the top part of the foot. If it's quite bad, it can cause a condition called foot drop, where the client isn't able to dorsiflex at the ankle. And it also can be heard by a more slapping gait as they walk. Coming down this way to the other end of the fibula again, if my client brings the toes towards them, we see this little area here? So that's a muscle. That muscle is the extensor digitorum brevis, and it goes from the toes to the edge of the calcaneus here. Just relax that for me. So we've got head of fibula and that pad of muscle, and in between the two there's a groove, and that's called the sinus tarsi. So sinus is cavity and tarsi is to do with the ankle. A condition there is sinus tarsi syndrome, which can be caused from an inversion ankle sprain. So if you imagine your client goes over on their ankle this way, and they can sprain the ligaments on this side but also strains this area. It can also be caused if your client is quite flat-footed and it puts pressure on that area, it squeezes that area as well. Medial foot structures. So we've got the bony landmarks, or the bones drawn on the foot here. From the medial malleolus, we've got a ligament. It's the main ligament of the medial side of the foot, called the deltoid ligament. Now the word deltoid comes from Greek for delta, meaning triangular, and it's a triangular ligament actually made of 4 separate ligaments going from the talus to the calcaneus. If you remember what this point is called, bonus point if you get that before I say it, the sustentaculum tali. I'm sure you all got that one, well done. And then moving around to the navicular. So we've got this triangular structure, the deltoid ligament, which is job is to prevent excessive eversion of the foot. Okay, so that's a deep structure. Now on top of that, there's this section here, which is known by the mnemonic Tom, Dick, and very nervous Harry. So this tells us 6 structures that go around the medial malleolus. Now I'm going to draw a few of them on. The first one I'm going to draw on is Tom. Now Tom is tibialis posterior. So this is the tibialis posterior tendon that comes around off the navicular, and it also goes to the 3 cuneiform bones underneath the foot and to toes, or the metatarsals 2 to 4. So it comes off there. It's the most important muscle to maintain the medial foot arch. And if that muscle's weak, then you can get a foot arch drop, leading to flat feet. So a really important muscle to work on if there is any pes planus. So that's Tom. Let us go to Dick. Dick is flexor digitorum longus. Might look similar in colour here, but we'll just draw that on. So same pathway, and flexor digitorum longus goes to toes 2 to 5. So that's to flex these toes here, okay, which is bending the toes forward 2 to 5. So we've got Tom, Dick, and is tibial artery. So we've got an and there. Tom, Dick, and very. Very's the vein. I've used my blue, so I'm going to draw a green one there. Nervus is the tibial nerve. And my last structure, I'm going to draw green again, is Harry. Now Harry is flexor hallucis longus. So hallucis refers to the big toe, which is the hallux, and it comes on the base of the foot all the way up to the distal phalanx. So its job there is to bend the big toe. On top of these 6 structures, there's another structure called the flexor retinaculum. And the flexor retinaculum is a band of connective tissue that covers those structures to keep them all in around the foot there. Okay, so that's the most superficial structure. There is a condition called tarsal tunnel syndrome. Tarsal tunnel syndrome is very similar to the carpal tunnel syndrome on the wrist. So it's any inflammation of or swelling around these structures underneath the flexor retinaculum, which can cause a lot of foot pain and also nervy sensations around the toes. We're going to have a look at some structures on the lateral aspect of the foot now. So we've got the end of the fibula, or the lateral malleolus, drawn here. We're going to draw the anterior talofibular ligament. Okay, a lot easier to say is the ATFL. So the ATFL goes from the fibula to the talus, and it's an anterior ligament. So we draw that ligament in there. It's the ATFL. Another ligament we have on the lateral aspect of the foot, just roll your leg over slightly, that's it, is the PTFL. Okay, so exactly the same, but this is preventing that posterior movement. And if I just grab another colour, just so we can see the calcaneofibular ligament, that goes from the fibula to the calcaneus. So they're the 3 ligaments on the lateral aspect of the foot. We can do a test, it's called the anterior draw test for the ATFL, which is the most commonly injured ankle ligament for any lateral ankle sprain. So we're going to get the client just to bend the knee slightly to about 20 degree of plantar flexion. Sorry, knee flexion. Grab the foot here, and I'm just going to shift the foot forward slightly. Now there should be a little bit of movement. It's only about 2-3 mil before you feel resistance. Okay, but that's nice and strong, that ligament. If there's excessive movement or pain, that can indicate an ATFL sprain. Then we can do a talar tilt test. So the talar tilt or inversion test is looking at the calcaneofibular ligament and the PTFL. So this time we're grabbing the calcaneus, we're holding the tib and fib, and you take them into inversion. Okay, so you can see the stretch in all 3 ligaments, in fact, but that would indicate pain on any of those ligaments there. We're going to have a look at some anterior muscles now of the shin. I'm going to start with the tibialis anterior. So with your client, if you get them to dorsiflex, bring their toes towards them. We've got a nice example here of the tibialis anterior belly, which starts at the top of the tibia. That's the main bulk of it. And then you can see it come down here, and with a bit of inversion, can you see that thick tendon? So it crosses the front of the ankle and attaches to the medial cuneiform base of first metatarsal. So tibialis anterior is involved with dorsiflexion and inversion. Just relax, client. There we go. Another one I'm going to have a look at is, or actually in the same position before Mark cramps up, this big toe, you can see it's extended. See that thick tendon there? So that's the extensor hallucis longus going to the big toe. And then the other toes, if you can make out at all, just resist that. The tendons of toes 2, 3, 4, 5. So that's extensor, and relax. Extensor digitorum longus. So the digitorum muscle goes to toes 2, 3, 4, 5, whereas the hallucis muscle goes to the big toe or the hallux. So they're the different tendons that you can see crossing the front of the ankle. We're going to have a look at the peroneal muscles. So back up to the head of the fibula, which we drew on earlier. So the head of fib is here. And the peroneus longus, I call it the Adidas stripe muscle, goes right down the side of the leg. We'll draw that on. It goes around the back of the lateral malleolus, underneath the peroneal tubercle, okay, which was that bony landmark we drew. And the longus goes just over that cuboid bone, underneath the base of the foot, and all the way round to base of first metatarsal and cuneiform. So I call it the stirrup muscle. Stirrups the foot from underneath, but it's coming from the lateral aspect. The other tendon you can see, and if the client everts their foot, so brings their foot outwards, turns their foot outwards, that's it. So there's one tendon here, but the tendon of the peroneus brevis goes down to the fifth metatarsal. So brevis meaning short. So that's the shorter peroneal. The long peroneal muscle goes right underneath the foot. And the peroneus tertius, tertius meaning third, is a muscle that is absent in 5 to 17% of clients. Now, how do we know that it's absent? Who knows if they've got one or not is the question. So it's done through autopsies or MRI scans to identify. We're going to have a look at range of movement of the foot or the ankle joint. So the main ones that people know are dorsiflexion, and dorsiflexion is where you pull the foot towards the body. If we think neutral or a zero reading, 0 degree is where the toes and the foot are pointing up to the ceiling. A reading is taken from that fifth metatarsal. So my client pulls their toes and their foot towards them as much as they can. You can see from a neutral position how much dorsiflexion there is. And a normal range of movement for that, just relax, is 15 degrees. So 15 degree dorsiflexion. Opposite to that we have plantarflexion, which is pointing the foot. And again, we can use the fifth metatarsal as a bit of a pivot or a landmark to mark from. So neutral is up to the ceiling, and we've gone into 55 degrees of plantarflexion is a normal range of movement, and relax for the foot. Other two pure movements at the ankle joint are inversion. Remember we did the inversion talar tilt. So inversion is 30 degrees. There's a lot more movement with inversion than eversion. Okay, and the reason behind that is the malleoli. So the lateral malleoli on this side comes down a lot further, and if you take the client into eversion, you feel a bony block there. Very common with ankle sprains, eversion ankle sprains, is as well as pulling all these medial ligaments, deltoid ligament, is to fracture the end of the fibula. So you get a double injury really. But only, I think it's 10% of ankle sprains are eversion sprains, 90% are inversion sprains. So we've got 30 degree inversion, 10 to 15 degree of eversion, and then other things at the foot, other movements at the foot you may have heard about are supination and pronation. So especially if you see a lot of runners, you hear about overpronated foots, but pronation is a combination of 3 different movements. So if I take my client into pronation, which is this forefoot coming down this way, that way, we have eversion, we have abduction, taken away from the midline, and a bit of dorsiflexion. So pronation in itself is a combination of 3 different movements, and supination, or creating that big foot arch here, is a combination of inversion, plantarflexion, and also adduction at the ankle. So you can't really measure pronation and supination as a degree because it is a combination of lots of different movements. We're on to posterior leg muscles now. So the main ones that people know of, or the main 2 of the calf, are the gastrocnemius and soleus. I'm going to draw the soleus first because it is the deepest muscle. So soleus, we said earlier, came from the head of the fib, so it's attached quite high up. It doesn't cross the knee, and then it comes down across interosseous membrane, which is the dense tissue between the tib and fib, and then it comes down. It's a wide muscle. Soleus, from the word sole or solefish, meaning flat. So it is the shape of a large flat fish going through into this tendon at the back of the heel called the Achilles tendon, and the Achilles tendon inserts right onto the top of the calcaneus here called the calcaneal tuberosity. So it stops around there. It only crosses one joint, it only crosses the ankle joint. So the action of this soleus muscle is to do plantarflexion. Nothing to do with the knee at all, it's just pure plantarflexion. On top of the soleus muscle, we have the gastrocnemius. Now gastrocnemius does cross the knee, so we're now back up here. And it attaches onto the femoral condyles. So where the knee joint line is, it's just above there, and it's got two heads. So we'll draw those two heads up. Now if we get our client to go into plantar flexion, point your toes, can we see the difference between these two heads here? We've got a medial head and we've got a lateral head. The medial head, just relax, that's it, don't want them cramping up. The medial head is larger and it comes down further. And gastroc, the word gastroc refers to gastroenteritis, gastric juice. Gastro means stomach. So gastrocnemius refers to the stomach, cnemius of the lower leg. And this goes into the same tendon, so it unites into the tendon of the soleus muscle and has the same attachment point. Okay, it's a little bit thinner, but it is longer. Now when I teach about gastrocnemius, gastrocnemius helps people remember that it crosses the knee. And because it crosses two joints, it's a biarticulate muscle. It has two actions, so it has plantar flexion, and then it also has a bit of knee flexion as well. Now there is a little test, quite an easy test, a way of looking at the Achilles tendon. So if you get your client to shuffle down the couch, shuffle downwards please, that's it, excellent. Now I'm going to squeeze these two muscles, squeeze the belly and the muscles, and I want you to watch the foot position. Okay, so just with one squeeze there, you can see the foot going into plantar flexion. It's called the Thompson squeeze test, which is a way of seeing if the Achilles tendon is intact. A test that I use quite a lot with clients with foot problems, calf problems, even going into knees, it's called the calf length test. And it's looking at the length of the calf muscle, but also looking at ankle mobility as well. So we're going to get our client up and against a wall. And the idea behind this test is, if we measure this one first, Mark, just put your toe, big toe on the wall and then try and touch the wall with your knee. Okay, so which is quite easy. And then slide back a little bit and you're going to find the biggest distance, try and touch the wall. You can come out from the wall, but you must keep that heel flat on the floor. So you're cheating a tiny bit, come in. There we go, and touch. Okay, good, so that's flat. I'm going to measure from the wall to the longest toe, which for Mark is his big toe. And we've got a measurement of 3 centimetres on that side. Just going to check the other side as well, Mark. Good, that looks a bit easier. Good, that's it, that heel's still flat. So this side looks a lot more mobile. Let's come in a bit. Good, okay, we'll give that a measure. And on that side it's 6 centimetres. So we've got 3 on the right, 6 on the left. A good range of movement, or healthy range of movement, is 10 centimetres. So there is some restriction, especially on this side. Now what that could be is, it could be to do with the plantar fascia, it could be the Achilles tendon, it could be gastric or soleus, or anything down that back line really. So it gives a starting position we can use for any kind of treatment, and then I'd reassess at the end of the treatment. Thank you for watching the video and spending half an hour with me. It was lovely to see you all, not in person. It does show you how important the anatomy of the foot and ankle is, especially with its relation all the way through up the kinetic chain up the body, and how foot problems, whether it's flat feet, ankle sprain, any injuries that you may have with this part of the body, can reflect up the body. So clients can suffer knee injuries, hip injuries. I've even had clients come and see me with neck problems because of a verruca on the base of the foot. So it does show how the injuries can flow up through the body. So we need to look after the feet, really important. I hope the anatomy we've done today has given you some extra knowledge that you can use on your course or in practice. If you've got any questions at all about anything we've done today, or about any other further courses or anything you might be interested in, then if you can contact me through my website, which is www.pressurepoint.me, and I hope to see you again in the future. Thank you and stay safe.